Just like to now start the first session, and unfortunately Professor Graham Thornicroft could not be himself. We're going to be having a video from him, and this will be available as slides later. I won't go on too much about him. He's an extremely illustrious man, and you have notes in there, but he's been the champion of mental health for Great Britain, and a very, very well recognised community psychiatrist, a very thoughtful man, and we'll be interested to hear what he has to say.
Good morning, everybody. I'm afraid I'm not able to join you in sunny Sydney. In fact, it's a cold, windy, miserable grey morning in South London at the end of January, but I'm glad to be able to contribute to your important conference. My title is The Mental Health Gap, Implementation Science in Deprived Urban Settings. And just to say a word to introduce myself to you, my name is Graham Thornicroft. I work as Professor of Community Psychiatry here at King's College London at the Institute of Psychiatry, and also I work as a consultant psychiatrist working with an early intervention team in Brixton in South London. Second slide, please. So in this talk I want to cover three things. I want to give you some of the context or the background about trying to understand and then to meet the needs of individuals in vulnerable and deprived groups, including those people with severe mental illness in urban settings. Secondly, I want to say something about an important new development from the World Health Organization, specific guidelines to help in the treatment of deprived groups. And third, to say something about the challenge of implementing these new initiatives. Third slide, please. So first, the context. Next slide. So what is the treatment gap? How do we understand this? This is a phrase increasingly widely used to describe one vital core idea. The idea is that of all the people in the world who have a mental illness, perhaps overall fewer than 10% get any treatment for those conditions. Now we know that these conditions in fact are extremely common. Survey after survey shows that in all of our societies, at least 20, sometimes maybe 25% or more, for example of adults, will have a mental illness this year. And yet, 2/3 or more of those people receive no treatment. Even in the richest countries, such as Australia, in England, the United States, we know that at best only 1/3 of people get treatment. And we know that at the minimum, for example, the World Mental Health Survey showed in Nigeria only 2% of people with mental illness get treatment. Now, there's no direct comparison, but we could think of diabetes as being a long-term condition, a condition with remissions and relapses, and we know that certainly in more economically developed countries, the vast majority, at least 3/4 of people with diabetes, do get treatment for their condition. Next slide, please. Now, a couple of years ago, this paper was published by Ormel and colleagues in the British Journal of Psychiatry, and it's one of those papers that just makes you sit back and takes your breath away for a moment. Next slide, please. So it shows the treated prevalence in high, medium and low resource settings, comparing some indicator physical conditions and then a few important mental disorders. In this case, it shows it by high or medium or low resource settings. And we can see that for the physical disorders, in the rich countries, the large majority of people getting treatment. Even in the poorer countries, at least a half, sometimes over 2/3 of people with the physical conditions are receiving treatment and care. The inverse is true for mental disorders. We can see here that in the rich countries, perhaps only 1/3 are getting treatment. In the poor countries, 10% or fewer getting treatment. So we are systematically neglecting people with mental illness across all settings, across all of our countries. Now, often such information is referred to as low and middle income countries, but I want to expand this concept to think of low and middle income settings, and in particular to think of deprived and vulnerable urban groups as living in, as having the experience of living in low and middle income settings, i.e. a deprived microculture within an affluent city or society. Next slide, please. So this one, titled Special Article from the New England Journal of Medicine, shows summary data from one of the American prevalence surveys, the National Comorbidity Survey. And you can see here, across the top row, the total prevalence of what they called emotional disorders. In this study, 30% of the adult population in the study year. And you can see that of those, only 10% were treated. So 2/3 of the people who are cases, identifiable cases, diagnosable cases, in fact received treatment. So from that we see that, if you press next slide, it shows that 1/3 of the cases were treated. So it was relatively poor coverage. Coverage here being the critical issue. Are people with conditions getting the help, the assistance, the treatment they need? In this case, the rich country, America, no. Then if we look down the row called treated, we can see in fact 20% of the adults were getting some type of treatment. But half of those were not diagnosable cases of mental illness. So if we press the next slide, you see that a half of those treated were not cases, showing poor focusing upon people who really need those scarce treatment resources. So, extending the argument then, are we talking about low and middle income countries or low and middle income settings? And I think for too long we've treated the rich world as if it offered everybody living there reasonable provision to access and care. But we know, of course, that certain groups, for example the homeless mentally ill, certainly do not have equal access, do not have proportionate access in relation to the severity of their needs and the complexity of their needs. So what I'm suggesting to you is that we can actually think about moving across the paradigm of low and middle income settings into rich countries, and suggesting that some of these groups may have magnified experiences of deprivation and neglect, even within otherwise affluent urban areas. Next slide, please. So there are then various levels of such neglect. One, as we've seen, is receiving no treatment at all, fully applying to at least 2/3 of cases, even among the richer strata of society. Second is whether the treatment received actually reflects the severity and complexity of the conditions, knowing that some groups, for example some immigrant groups, for example those in forensic or secure settings, for example those who are homeless and mentally ill, will on average have more problems and more severe problems. And third, particularly in relation to institutionalized or indigent groups, are we paying sufficient, in some cases are we paying attention at all to the various comorbidities, especially for mental disorders, for alcohol, for substance abuse, and for physical health needs, including prevention of preventable conditions, particularly related to alcohol and tobacco. And the answer, of course, to all of these is no, we're not yet, nor have we communicated to policymakers the nature and the extent of this neglect. So I want to talk next about the World Health Organization Mental Health Gap Intervention Guide. And this was launched, the whole program was launched now 2 years ago by the Director General of the WHO, Dr. Margaret Chan, and is now the centrepiece of the work of the Mental Health and Substance Abuse Division within WHO in Geneva. What is it for? Well, the mental health gap objectives are to increase the commitment of governments, non-governmental groups and other stakeholders, and to increase the coverage. That means to increase the percentage of people with conditions who are getting treatment, and specifically to focus on low and medium resource settings, not just countries, but settings. So in terms of the development or the strategic way that this program has gone about its business, and I was involved in co-chairing the process, we set a number of priority conditions and then deliberately wanted to create new ways of scaling up services to meet the need and to build partnerships. Very commonly, not just in low-income countries but other settings, the normal single governmental route will not do to meet the need. Often there need to be partnerships between all sorts of sectors which historically have not necessarily been close collaborators. So the mental health gap priority condition criteria is shown in the next slide. Those causing high burden, which have a high economic cost, where we do have effective interventions, and which affect vulnerable populations, including the topic of your conference today on urban mental health. And the next slide shows the 9 conditions which were selected as the content for these new guidelines. And you can see, I won't go through all of them, but you can see depression, psychotic disorders, dementia and so on, the sort of headings that you'd expect. Also, perhaps some headings you don't expect, remembering that in especially low-income countries, the psychiatric services have to deal with everything in mental health, and also conditions such as epilepsy and learning disabilities, which come to them for the lack of any other service being provided. Next slide. So this slide entitled Mental Health Gap Intervention Packages. Just to introduce this is a radical departure for the WHO. Until now, they have produced documents to go to the national level, so-called technical assistance, technical advice governments, for example on policy, on human rights and so on. This is an entirely new type of contribution. Guidelines intended for practitioners on the ground. So, the group that produced the guidelines, altogether about 70 people from many countries and continents, went through all the background literature that existed, found important gaps in the knowledge, so commissioned 93 new systematic reviews. We pulled together all the material from low and middle income settings, which is relatively few studies. We then had the job of trying to filter out evidence from rich countries to see how much could be applied, particularly to low income countries. And we've now produced something called the Implementation Guide. But still, this is an international template. And the next step is to produce country adaptations and versions suitable for particular target groups within countries as well. So next slide, and press again to show the front. The Mental Health Implementation Gap, Intervention Guide, has just been launched a couple of months ago. It's based upon the very best evidence that we can gather relevant to low-income settings and groups. It's designed to be used by general, especially primary healthcare staff, not by specialists. Because not just in low-income countries, but in low-income settings, perhaps in institutions as well, there may be scarce or no mental health specific resource. So these are designed to be clear and to be simple enough to be understood, for example, by primary care nurses. And to include not just pharmacological but also social and psychological simple interventions. So the next slide is called MHGAP IG Master Chart. And you can see here down the right it says depression, psychosis, epilepsy, developmental disorders, simple bullet points for the practitioner in the field to identify a case and to put the person on the right track for the treatment assessment. And on this next slide you can then see the other main categories: behavioural disorders, dementia, alcohol use, drug use, suicide, self-harm. So those are the main pathways under which treatment is organised. Next slide. Just to give you one example about the structure of this. This is the guideline for developmental disorders. You can see it follows a sort of decision tree or algorithm structure, with if yes, go here, if no, go there, designed to be very simple. It's deliberately designed to be similar to a system already developed by the WHO called IMCI for the treatment of children's disorders, and that has been phenomenally successful. It's now in use in over 100 countries, in most of the poor countries in the world. So the next slide also gives you a little bit more detail about the nature of the information provided. This is called Developmental Disorders Intervention Details. You can see here outlines of the psychosocial information, in this case advice to teachers, community-based rehabilitation. So it's deliberately giving a broad and practical view about social and psychological and pharmacological interventions where they are evidence-based, and good practice, such as information to the individual concerned, to the family member, and to any other people who need to know. Simply, if you type in WHO Implementation Guide, then you will find it. And here you can see the Geneva website to get the full document, which is downloadable as a PDF.